Good morning and welcome to my YouTube channel Pain Free Partha. Today's topic is about perioperative visual loss. So why we should know this? Visual loss after anesthesia in surgery is a rare, unexpected but devastating complication. What is it? It is a permanent impairment of sight as either a partial or total associated with non-ocular procedure. Usually general anesthesia is administered. So because regional anesthesia or blocks, it is not concerned with. General anesthesia usually is given, a non-ocular procedure is being done, and you get an ophthalmic injury in way of either vascular, ischemic or physical injuries, causing to an impairment of sight. This is what is called POVL, perioperative visual loss. So in history, Goodell noted, we still see too much of conjunctivitis, keratitis following anesthesia. So what happened was, see this thermal mask was there, ether was poured. So the mask more prone, light and opened eyes. So light anesthesia, opened eyes, a big gas piece, ether is poured. After the introduction of laryngoscope and intubation, perioperative visual loss decreased. The incidence is 1 in 60,000 to 1,25,000. It is most common after spinal surgery, can be have after cardiac surgery, head and neck surgery, nasal or sinus surgery. Now we come to a simple conclusion. Its incidence is 1 in 60,000. Commonly after spines, back, cardiac, head and neck, nasal sinus. These are the surgeries in which this incidence of POVL is likely. Now it can be what? It can be a direct damage to the vascular system. It can be a compression of retinal artery by a hematoma. It can be an intraarterial injection of local anesthesia. It can be a direct damage to the external ocular apparatus. Now what surgery I have already told, spine is 72%. Cardiac, all other things are miscellaneous. What are the risk factors? Spine fusion surgeries, blood loss is more, prone position, GA, hypotension, transfusions, all these things are risk factors. And this Wilson frame is more prone for this perioperative visual loss. There are so many other factors like a steep Trendelenburg position. A direct correlation between duration of surgery spent with an increase in IOP, resulting in reduction of perfusion pressure, sometimes below IOP, perfusion decreases. More than 30 degrees, see more than 30 degrees for more than 2 hours. Then put it back again and put it in. Now I am telling you, put it back again for some time and then go back again to steep Trendelenburg position. Now we can have damage external, we can have damage in the which is humor, we can have damage in the retina, we can have damage in the neuropathy, we can have damage in the vascular system. Blood supply to most of the eye is supplied by the ophthalmic artery, and in the retina it's a central retinal artery. So where it gets compromised, when it is anemic, when the BP falls, the IOP increases. The IOP increases, the perfusion pressure decreases. So when the BP is less, when the anemia is there, so all these things make a compromise of this vascular supply. Venous drainage, central retinal vein. Now, what are the types of injuries we can have? External or direct physical, and we can have physiological. So what are the external or ocular injuries? We can have corneal trauma, irritation, abrasion. Many of the time we do a modified radical mastectomy. We are not properly closing, and after the end of the surgery there is a corneal edema, irritation, small abrasion, small lines. All these things are dangerous. External ocular injuries. because we have not taken care of the eyes properly. So go about to prone position. Again, the risk is very high because of the external ocular compressions. Who are prone and different prone? This is different prone. Who are prone for this? Prone patients are prone for this. Altered facial anatomy, exophthalmos, patients belonging to their lower nasal bridges, all these things. Now, venous, why prone is problematic? Because in prone position, venous return decreases and cardiac output decreases. There is a PEEP and we are giving this. This decreases venous return. An increased IAP again decreases venous return. Intrathoracic pressure is high. Venous return is decreased. So cardiac output is decreased. Here, if the patient is obese, then the abdominal compression pressure also comes. See here, there is only IAP. Here it is abdominal compression here, which is pushing here. And so, in obesity, this probable decrease in venous return and the cardiac output is more in obese prone patients. See here, there are so many facial contour anatomies, exophthalmos, all these things makes patient prone for visual loss. So we can do this every 20 to 30 minutes. We can release this compression slightly or some other thing and then put it back again. There are a lot of devices which can protect this so-called ocular injuries. This is about external ocular injuries. Now we are going to some other things like anterior ischemic optic neuropathy, posterior ischemic optic neuropathy, CRAO, central retinal artery occlusion, branched retinal artery occlusion. We don't know whether exactly the human optic nerve has the ability to autoregulate where the brain does. Posterior ischemic optic neuropathy is common. CRO is less common. So posterior ischemic optic neuropathy is the common thing. Now, if we want to go in the discussion pathophysiology wise, CRAO, BRAO, external compression of the eye, decreased arterial supply, embolism, impaired venous drainage, arterial thrombosis, all these things are possible. Retinal embolism, microembolism for cardiac surgeries, hypotension, radical neck dissection and IJB ligation. So back again pressure goes up. All these things go to a decreased vascular supply through the CRA. Clinical findings is pupillary painless loss of vision, pallor and cherry red, abnormal pupillary reactivity. Retinal and choroid vessels also supply. So if the compression is going to be both, then there is a danger even if in a crude CRA. If you are at least okay with choroidal vessels, then the danger is less. But if you are compressing and both choroidal vessel is compressed, CRA is compressed, then there is a danger. Super selective injection of cormestin into the internal carotid artery to treat gliomas. Cosmetic surgery is fat injected into the orbit. So anesthesiologists should be ready and should be aware of these complications. Where there is an injection of cormestin for gliomas, fat for cosmetic surgeries. Local infiltration in nasal septal injuries. Sometimes it may cause platelet aggregation and retrograde embolizations. Usually it takes 100 minutes. After that, it is usually irreversible. So whatever is the treatment is prevention. Position, headrest, and adrenaline beware. If it happens, there are so many things. Acetazolamide, local cooling, thrombolysis have been described. We will come again. Ischemic optic neuropathy. You can have area of anterior ischemic optic neuropathy, area of posterior ischemic optic neuropathy. This is common. Here is the optic disc. Steroids. Periop. Spine. This is cardiac. Posterior ischemic optic neuropathy is spine. Anterior may be due to cardiac. There are numerous mechanisms. Increased IOP, decreased blood pressure, altered autoregulation in a setting of diabetes, hypertension, hypoxia. All these things are risk factors for this vascular injuries. Smoking. Long duration surgeries, decreased venous return can cause interstitial edema. So long duration surgeries, decreased venous return, decreased cardiac output for some time, prone position, and the patient is having anemia, blood loss. All these things make an perioperative visual loss prone patients. Recovery may be up to 24 to 40 hours, painless visual loss, unilateral, pupillary defect, complete visual loss, no light perception. And altitudinal, see whether the optic disc edema is there, it is AIOM. Optic disc normal means PAOM. So orbital MRI is usually normal. Now the problem is the patient has got some visual loss. It's a major surgery in prone. And now we have come back to supine and everything is closed. Nobody sees. Unless the patient comes out of anesthesia and tells I am not able to see, we are not able to see. Patient is on mechanical ventilation post-op. It will obscure and confuse. We will not find out this perioperative visual loss at all. Now we know 25% reduction in blood pressure, 40% blood loss, already anemic, the use of vasopressors in a patient with atherosclerosis, dyslipidemia, diabetes, hypertension, smoking. Yes, we are in, especially in prone position where the problem of decreased venous return, decreased cardiac output in a setting of PEEP, increased IAP, obese patient causing abdominal compression pressure. So lengthy surgery, sleep apnea syndrome, all these things. There are no studies properly. It's because the thing is little rare. And if it is going to be rare, then it is very difficult to conduct studies because we may need to examine some 70, 80,000 patients to find out these things. Evaluation, it should be fast. There should be an urgency, but it should be scientific. Neuroconsultation and ophthalmic opinion. CT scan and CT angiography. Where is our mind? If it is going to be cortical blindness, CT scan. If it is going to be vascular, we may need to go for CT angiography. Consult neuro, consult ophthalmic. Intraoperative visually evoked potentials. This can give you a clue. And they have found out that there is a little better with TIVA rather than with agents with regard to intraoperative VEP giving a clue to the so-called visual loss. So now we have already touched on some amount of risk factors to be avoided, staged procedures, head abuse, and colloids. Steroids, we have already told arthritis is there. Diuretics to decrease IOP. There is going to be antibiotics, head up position, give vasopressors or whatever it is, IV fluids to increase the BP, lateral canthotomy in case of orbital compression syndrome. Now, what is cortical blindness? Bilateral visual loss with an absence of optokinetic nystagmus and lid reflex rounds to thread. It may be unilateral, maybe pupillary response, eye motility are normal. See, because it's cortical blindness, you cannot see it. But pupil, if you give it a touch, it doesn't go to cortex, so it does so that the response is normal. So we may need to think of stroke, especially in cardiac surgeries. If the perioperative vision loss is due to cortical visual loss, you may find out with imaging. Occlusion of cerebral artery contributes to deficit within a sensitive window. There may be a role of intravascular clot retrieval or thrombolysis. Now we know there is a perioperative visual loss. Now it is cortical, we know. Now you know there is some internal artery, some artery is having a clot. Yes, in this situation, there is a chance of thrombolysis or a clot retrieval. Pituitary apoplexy, the vision loss is present upon awakening from anesthesia. Bitemporal hemianopsia, headache, nausea, vomiting, so many signs will be there in pituitary apoplexy. Visual recovery from cortical blindness may be prolonged, may or may not recover. Focal neurological signs, then we should target the stroke. Acute glaucoma, rarely after GA 0.02%, but ION is an younger age. Painful red eye, yes, increased IOP, acute glaucoma, and can cause visual loss. There we may need to give analgesics, beta blocker drops, and may go for a surgical intervention to decrease the IOP and decrease the glaucoma and thereby improving vision. Turk, 24 to 48 hours visual symptoms can happen. Glycine has been implicated, ammonia increase has been incubated, and IOP increase. Visual loss after vitrectomy or bubble dampened is completely different because we are treating the eye, where POVL is not about ocular surgeries. Post craniotomy visual loss. Patients with chronic papilledema caused by some intracranial mass may lose vision within the first few days post decompression blindness. Decreased CSF pressure in triacetic and a scar may block the communication. So we may need to do optic nerve sheath decompression as a treatment. No evidence that an ophthalmic or a neuro-ophthalmic preoperatively is okay. Now I'm going to a spine surgery for 8 hours. I'm going to an ophthalmic opinion, neuro opinion. Nothing is going to predict that this fellow will go for a POVL. So what is the definition? It is a temporary, a mostly permanent visual loss after a non-ocular procedure under general anesthesia. So various types of surgeries, spine, cardiac, sometimes nasal surgeries, craniectomies. What are the risk factors? Procedure in prone position. Duration of surgery is more than 5-6 hours. Blood loss, preoperative anemia, persistent hypotension was there. We have not changed the position now and then. All these inner setting of diabetes, hypertension, dyslipidemia, smoking, then these are all the risk factors. Prevention is the best one. Treatment depends upon the cause. Cortical blindness or PION, anything. Steroids may be helpful in certain settings. Craniectomy or optic sheath decompression may be helpful in settings. So we may need to give point to whatever the cause is about. So this is about AION, PION, external ocular injuries, and cortical blindness. So you can access my slides in painfreepartha.com and YouTube as